TNT Open Mind Insights brings you powerful, authentic conversations, illuminating the path to better mental health care for all.
Welcome. Thank you so much for joining us today to talk about yourself and the work you're doing and all the insights you may have to share with our audience. Thanks for taking the time.
Thank you.
Yeah, so I am really one of the first questions I always ask. Our professional lives are so important, but there's usually a personal motivation for spending such a big chunk of our life doing something.
Mm,
And you are dedicating your life and your career to psychiatry and addiction medicine and how those interrelate, and you're teaching and sharing knowledge. And so, my first question is, where does your motivation come from? Why do you care about these issues?
mm,
You could have chosen anything.
Thank you. Well, it's a funny story. My parents were actually clinical psychologists. I grew up in the Philadelphia area, and my mom's father was an internist, and my dad's father was a psychiatrist. So there's a little bit of history there.
Yeah.
Um, I made a decision later in college to switch tracks from more of a public policy track to medicine. It was kind of an emotional decision at the time related to my grandfather's legacy, my mom's father, who was an internist. And, when I got to medical school, I was really focused on primary care because I thought it had the greatest intersection with policy, and that's where there would be opportunities to kind of blend those interests. And I had been a little more skeptical about emotional health and mental health, going into medical school for a variety of reasons. And I kind of discovered around my third year of medical school that, I was doing my psychiatry rotations, and I was really coming to believe that there was a big difference between emotional health and a lack thereof from what I was seeing professionally, but also seeing in others around me. And it really changed my kind of view of that whole field and that whole discipline. And I think I was hesitant to embrace psychiatry because, uh, you know, as clinical psychologists, my parents were, a little bit skeptical of kind of brief psychiatry visits and
Mhm.
some of what they saw in their practice. But I think once they saw, how much I liked it, they were kind of on board. And yeah, around that time, I also noticed that people with addiction and co-occurring mental health disorders, not only was I seeing them, but they were making really incredible recoveries.
Oh.
And I thought, this is kind of where the action is.
Huh.
Um, and I think, anybody who goes into medicine kind of, they find their version of where they see change happening. And for some people, it's in the operating room. And for me, it was really around this area of emotional health. The last thing I'll say is that I think it connected with something in me that uh, was sensitive to other people's moods and feelings, and that kind of an awareness and a curiosity was something I think was always in me, but I don't think I realized how well it would connect with psychiatry until I learned about the specialty and
Mhm.
things like that.
So, do you feel that your work is connected to policy now? That was something, an early interest of yours, and you mentioned it as part of your interest
Yeah, good
later too.
good question. You know, when I was in medical school, I did do some policy work in Tennessee, actually around the childhood obesity epidemic.
Hmm.
Um, when I went into residency in psychiatry, residency was so busy that I didn't do much on the policy side. But when I came back to Tennessee in 2018 to join the faculty at Vanderbilt, I was just trying to look for ways that I could help in this specialty area of addiction medicine, which is very focused on addiction psychiatry. And so I was involved in some things, talking with the legislature at times about different areas. Um, the biggest involvement I've had is serving as the principal investigator for a state contract that pays for care for uninsured patients at Vanderbilt for opioid use disorder. And so in that role, I helped integrate care for uninsured into the care system at Vanderbilt for addiction, and was in that sense kind of working for the executive branch of the government in
Oh,
Tennessee,
wow.
the Department of Mental Health
Wow.
and
Interesting.
Substance Abuse Services. So yeah.
Wow.
Yeah.
So now it's like a confluence of three things.
Yeah, well, it's important to know that if you're a PI for a state contract, that you have to be mindful of that if you're doing advocacy, because there can be conflicts of interest
For
and things
sure.
like that. So I try to do my part on areas where I think I can make an impact, but it's a niche
Mm-hmm.
for sure.
Yeah.
Yeah.
So what are the areas of impact or the change that you wish to be a part of? What
Hmm.
would you like to see different?
Well, I think this is a part of it. I think this program, that Dr. McCarran has started with TNT, um, we're seeing, we're told that there are shortages of primary care doctors and psychiatrists, and I think we know that there are problems with the payment system, but that there are shortages. And I think what we're seeing is a lot of advanced practice providers are coming through training, but the training itself doesn't always prepare them for treating psychiatric conditions and addiction. And so I think that being part of this program feels like being part of the solution, because
Mm-hmm.
patients, they deserve to have providers with expertise who really understand what they're seeing. It's what you or I think, would want for ourselves, for our family members. And so I think education of primary care doctors, general psychiatrists, advanced practice providers, I'd like to see that expand.
Yeah.
Yeah.
Yeah. So it seems like the hope then with this program is that some of these people can be treated within their primary care environment effectively and then reduce the number of referrals to get to you or other psychiatrists.
Yeah.
Yeah.
I think that's right, and I also think that there can be a finer tuned sense of who to refer and when to refer,
Yes.
because it's not always clear where the line is. We know the line changes if you start to know more about the specialty area,
Mm-hmm.
and we do think that there will be people who need specialty referrals, but if we
Mm-hmm.
can fine tune that, then that could help.
Yeah.
Yeah.
Yeah. So I'd love to hear more about what you've learned about, psychiatry and addiction medicine together. How
Mhm.
are they related? How do they interact?
Yeah.
How do we approach this topic that maybe can't be sussed out in two different areas
Yeah.
so well?
Yeah, it's a good question. I didn't believe it until I did the fellowship, but my mentors would tell me that becoming an addiction psychiatrist helps you a lot as a general
Oh,
psychiatrist.
interesting.
Yeah,
Huh.
and I think um, you do notice addictive tendencies, or ways of thinking about things that are analogous with addiction when you've done that training. I also think that we don't always see what we're not looking for, and
Mm, yeah.
so um, it may be that somebody's not getting better, and we don't know that there's an addiction that's fueling a cycle of anxiety or depression. Um, People will ask which comes first, right?
Mm-hmm.
Other mental illnesses or addiction. And trajectories are different for everybody, but we know that there are these four underlying risk factors for addiction: depression, anxiety, impulsivity, and sensation seeking. So when somebody says, well, all addiction is related to untreated depression, or all addiction is related to untreated anxiety, it can be a little bit of lumping rather than
Yeah.
splitting, maybe too much. But I think if we try to understand, what was somebody's underlying vulnerability, if we really ask them about periods of their life before addiction started, if they can remember periods when they were sober, we can usually get a good sense of, are there both? Is it one or the other? And unfortunately, in our field for too long, there's been this attitude that you can't diagnose an underlying mental health condition when somebody has an addiction.
Oh,
And
interesting. Yes, I've
mhm,
heard that before.
you've heard that,
What are
yeah.
your thoughts on that?
Well, it's really problematic,
Yeah.
because what it leads to is this reductionism where patients come into addiction treatment, and they may not be asked. And if they are asked, it may not be done in a way that really differentiates people who develop depression because of their addiction issues versus people who had depression and then developed addiction because of it. And if you don't know, then you might miss an opportunity to start effective treatments, medication or psychotherapy. And so people have much slower progress, and in some cases, they may not really recover for years. They may go through cycles of residential treatment until the underlying issue is diagnosed.
Wow. Yeah, that's really interesting. So, how do you want to approach that particular route? Like, what
What,
would your insight be into that?
Well, personally, I have my approach of how I ask people about, very deliberately try to anchor them to periods of sobriety, either before they started using substances or since they've started using, or they've had at least a month of sobriety.
Hmm.
And then I try to really ask them about not just were you depressed, but did you have at least 2 weeks where most of the day, every day, you couldn't enjoy anything or didn't want to do anything? It's a
Hmm.
very different question.
Yeah,
And so that's my
that's
approach,
true.
but I think, I'm sorry.
I was, no, I was just going, oh, yeah, that makes sense.
Yeah,
Yeah.
that's my approach, but also it's like we were talking about, it's about teaching that, because it's very different if you get a module, if you get a lecture on addiction and you get a lecture on depression, but you never get a lecture on both
Yeah.
and the interaction, and then you go out into practice, you may not know how to ask about those issues,
Hmm.
and that's even the best case, because it's one thing to know how to ask about the diagnosis. It's another thing how to know how to talk to patients in a way that brings out a vulnerability. And so there's a lot to learn there.
Yeah, that's tricky
Yeah.
because you have to be a doctor, a scientist. You've got to note all these things, keep records and whatnot, and then also have those personal skills.
Exactly. If you want to attend to what the person across from you is feeling about the conversation, you've got to you've got to learn the checklist, and then you've got to move beyond it to where you've
Hmm.
internalized it.
Yeah.
And so, unfortunately, I think, and this is at risk of it being a soapbox, I think that there's not always an understanding of the difference between having many years of training and practice in the clinical environment versus being in the classroom and then going off to try to treat people. It's very, very different.
Yeah, that makes sense. But I know TNT also they teach, motivational interviewing or these techniques in order to bring out that comfort level so
That's right.
people can share things.
That's right. And motivational interviewing, when I have medical students rotate with me on, let's say, the addiction consult service in the general hospital, where we know we're going to see patients with addiction and co-occurring disorders, there are only two things that I think they really need to be oriented to at the outset. One of them is how to diagnose co-occurring disorders, and the other one is motivational interviewing.
Wow.
Because the only way they're going to get reliable information from patients is if they know how to talk to them. And it's amazing how, the old joke was the medical student would go to talk to the patient and ask, when's the last time you used any opioids? And the patient would say, a month ago. And then the resident would go and ask, and the patient would say, a week ago. And then the attending would go and ask, and the patient would say it was yesterday.
Wow, that's
So,
interesting.
same question,
Yeah.
three different people, three different answers. So you start to
Huh.
wonder, how was it asked? How was it asked?
Yeah, what is the answer to that question? Do you think it was the nature of the power dynamic could come into play, or do you think it's
It,
the way
it,
the
it should
question is
ideally
asked?
be the opposite, which is that the medical student in the hierarchy of medicine has less power, but do they know how to use power and how to minimize that sense of authority with the patient? Because
Hmm.
really, what you want to do is you want to come in and immediately assure the patient of your respect for them
Yeah.
and your respect for their autonomy and your understanding of how hard it is to be in the hospital. So the way you provide affirmation, the way you ask questions, whether they're open-ended or closed-ended. So same scenario, if you go in and say to the patient, I heard you wanted to stop using opioids, and the patient says yes, that's very different than if you say, how do you feel about your opioid use?
Hmm.
And if you start the conversation on the assumption that they want to stop, they may immediately be thinking, I've got to be careful what I tell this person because I think this person has an agenda.
Yeah.
Whereas if I come in and say, how do you feel about your opioid use? It's a very different energy.
Yeah.
So I think that's part of the answer.
Yeah, that makes sense. So that's giving them a say in their own treatment in their situation.
Exactly, because
Yeah.
they have their own reference point for why they were using opioids and how they got
Mhm.
to that point.
Yeah. So you have a specialty in both of these areas,
Mhm.
but how many psychiatrists have training in addiction medicine?
Well, it's interesting. It gets a little bit technical, and I'll try to not get too in the weeds. But there are two different fellowships that are approved by the American Board of Medical Specialties. One of them is called addiction medicine, excuse me, and the other is called addiction psychiatry. So they are two different specialties, and some people will train in both, but most people train in one or the other. So any physician who practiced clinically and did a residency can apply to do an addiction medicine fellowship, including psychiatrists. But only psychiatrists are eligible to do an addiction psychiatry fellowship. A lot of the same things are taught in those fellowships, but addiction psychiatry fellowships tend to have more psychiatrists doing the teaching.
Yeah, that's really interesting. That's really
I
interesting.
don't know if it is. I wonder if that's a little bit too in the weeds. Did I actually address what you were asking?
Yeah, yeah. I just didn't know because it seems like it's important knowledge for psychiatrists to have. And
Mm.
then how often is it that um, do people get referred to certain psychiatrists because of their specialty?
Yeah, so it's actually sort of a an issue that we've been trying to address in addiction psychiatry, which is what training do general psychiatrists get? And it's the same on the addiction medicine side. I mean, there are a lot of addiction medicine champions who are looking at, well, should primary care residents, family medicine, internal medicine, should they be getting more addiction training in their general residency? And so both sides are looking at that. And we've
That's
tried
good.
to encourage the ACGME over the years to require more addiction training in general psychiatry, but it's always a little bit of a back and forth because there are so many things that these trainees have to learn, and so there's a lot of stakeholders. But you're right, it's really critical when we look at the rates of addiction and overlap with co-occurring disorders. We think that residents need to be prepared to diagnose and treat, even if
Makes a
they
lot
didn't
of sense.
subspecialize. Yeah.
Makes a whole lot of sense. We're continually going back to this idea of breaking down silos and breaking down these um, separating of issues because as human beings, it's all going on at once.
Exactly.
Yeah,
Exactly.
yeah. So, um, what excites you the most about what's going on currently with addiction medicine and, and psychiatry
Yeah,
together?
yeah, yeah. Well, I think that this generation is empowered in a number of ways because they're tending to be more open about mental health and addiction. They're getting that encouragement. Of course, we don't need to look far to see that there is an opioid crisis, there is a fentanyl crisis. And so parents are more interested than ever in understanding these issues and talking to their kids about these issues, which I think sets a different tone for them about being open to treatment. I think also the digital revolution, which it's not like it just happened, but now we're in the AI revolution. And
Yeah.
so that generation is getting more and more comfortable turning to virtual platforms. Certainly, COVID totally changed the delivery of telepsychiatry and telemedicine and opened up a lot of new possibilities. So I think when you combine that virtual revolution with people using new digital tools, there's a lot to be excited about and to be cautious about, I think.
Yeah. And then what are some of the primary kind of overarching ideas that you, because you teach a lot,
Mm,
what are those kind of nuggets of wisdom that you want your students to come away with from
mhm.
having been taught by you?
Well, as I mentioned, there are two things I'm really passionate about teaching about, and one of them is diagnosing co-occurring disorders, and the other is motivational interviewing. The difference between the two is that you can teach diagnosis of co-occurring disorders fairly quickly. You could
Yeah.
talk to students for a couple of hours. You could maybe talk with them twice for 2 hours or something like that, and then they could go off and they could do it like we talked about. They do the checklist and then they practice it a couple times and they're ready to make those diagnoses. Motivational interviewing, on the other hand, requires a lot of sustained practice. And unfortunately, our medical students don't get nearly enough to feel comfortable. When I lecture and do small groups with them on motivational interviewing, I've taken to telling them, this won't be enough. You will need to practice this. And to get practice, to get supervision, to get feedback on what they're doing, because people do a lot of things unconsciously when they interview patients.
Yeah, I'm sure.
And, I'll give you an example from the lecture I gave here yesterday, which is that for better or worse, we do a lot of urine drug screens in addiction medicine. And a patient may, be ashamed if they return to use of opioids. They may be embarrassed. They may be defensive. They may say, no, I didn't do it, even though they may be thinking, actually I did, I'm in trouble here. And if our response is to say, I believe you, right, which is a very normal response when you have a dynamic, a relationship with somebody, because I don't want you to be worried, I don't want this to be a stressful interaction, I might miss an opportunity to actually just reflect back what you said, which is, you're surprised. Now, feel the difference between those two responses. One, I believe you, I trust you, totally changes the nature of the conversation. Now, all of a sudden, I'm saying something to you that I don't really mean, and you're having to respond to it. It
Yeah.
takes a lot of reality out of the encounter. Whereas
Yeah.
if I say you're surprised, now I give you a chance to talk about what's really going on inside of you. So it's a small example, but it's one of many where if we're not mindful, if we don't have practice, if we don't get feedback about what we're actually doing, we may inadvertently cause harm, cause patients to not share with us, not get accurate information. And so what I always say is it's pretty shocking that we have this technique that we know works. We know that it's more likely to get patients to make changes, and we're not teaching it, we're not doing it.
Oh, wow.
So I'd say that's the area I'm most passionate about in medicine.
Oh, that's really interesting because I conducted a bunch of interviews with fellows last summer, and most of them said that the information on motivational interviewing was their favorite topic. They really loved that because
Yeah.
it's like, honestly, they're spending most of their days interviewing people,
Exactly.
essentially.
All day.
But that piece of it didn't really have a formula. Like some people just may naturally do it better. But there's
Yes.
actually techniques.
There's techniques to cultivate empathy if it doesn't come naturally to you, and empathy is one of the sine qua nons of motivational interviewing. The other thing that's really important about this is burnout, right? So there's a lot of talk in healthcare about burnout.
Yeah.
But what I would say is that I think one of the big drivers of burnout is that people feel like they're not making a difference. They're rushing all day, they have 20-minute visits, and they're trying to convince patients to do things. And in that kind of a setting, the worst thing that can happen to you is that a patient is telling you they don't want to do the thing. Never mind that a lot of patients are saying yes, but they don't mean it. So you start to realize that you're having a much bigger effect on patients when you're trying to let them be in charge and you're not trying as hard to push. So when you teach MI, you're actually helping reduce burnout because the physician or the provider is not working as hard, but they're getting better results.
Oh, that's the sweet spot, then,
That's
isn't
the
it?
sweet spot, exactly. And so it's a big difference.
I love that. I love that. I'm always looking for that in my business too. It's like, what are the techniques that can be used that will increase my success as a business, but also be easier?
Exactly, exactly. There's that whole idea that 10x is easier than 2x.
Isn't that funny?
Yeah.
Isn't that funny? It's like that win-win situation.
Exactly.
Yeah, yeah, that's wonderful. So you seem like a really compassionate, empathetic person. Like you want to see your people be successful, your patients, you want to see your students be successful.
Thank you.
You know, why do you care about your fellow humans?
Oh, that's a tough question. I mean, I think it's how we're hardwired. I mean, I know
Not necessarily.
Not necessarily?
Okay. Or maybe
Well,
some are more in touch with it than others.
I'll say that people wonder about this and they wonder about human nature. there's a cousin of motivational interviewing, which is called nonviolent communication. It was
I've heard that.
pioneered, you've heard about it? It was pioneered by this psychologist, Marshall Rosenberg. And one of the things he says is that we're really hardwired to ask how to make life more joyful and more wonderful for other people. But there have been a lot of things historically over the last several thousand years that have led us to use language that is violent. And that language serves those who benefited, hundreds, thousands of years ago from having kind of an us and them, a monarchy, a war, a conscription, a draft. And so in that paradigm, it's very important that somebody be right and wrong. It's very important. But in nonviolent communication, we ask what needs exist for the other person, what needs exist for me, and what feelings are brought up when those needs are met or not met. And so without trying to get into all the details of how it works, the basic premise of it, I think, has resonated more and more with me, which is that when I'm resourced, when I have the energy, when I'm taken care of, when my needs are met, and I can sit with another person and really try to make their life better or bring them joy, it feels good. And I think that's really how we're hardwired. But there's a lot of things that get in the way of us being resourced, of us having our needs met.
100%. Yeah, I'm way on board with that because I've noticed that in my own life as well. The better I'm doing, and now I put a lot of effort into my own self-care. I spend about an hour in the morning just for myself, for meditation and prayer, things like that, just to give myself the energy I need to go into my day and give to other people. And then when you give to other people, it comes back to you, gives you more energy, and then there's just this positive loop that keeps going. But so often people suffer because then they get on this negative loop. So they get more and more depleted.
Yes.
And then they're not able to give back, and then they feel worthless, and then they get depleted. So then the people that are in a positive loop need to kind of help them.
That's right.
Pull them out.
And it's very relevant to our conversation because historically healthcare providers have been taught that this is a calling, this is a duty, and that's not bad. I think there are benefits to that mindset and training of feeling you have a profession and a commitment. But the downside of it is that you don't develop that muscle of knowing when are you doing things that are alive in you and when are you doing things out of obligation, guilt, shame, fear. And if you don't build that muscle, then you don't know sometimes until it's too late. To your point, you've gotten in a negative loop, you've burnt out, but you could have noticed much sooner that you needed to take more time for yourself and you needed to maybe make a change.
Yeah. So on that topic, how do you fill your own cup? How do you stay positive?
Great question. Well, I'm very fortunate. My health is good. I'm able to exercise pretty regularly. I have a family at home, a wife and kids that keep me humble and provide me with a lot of support and a foundation of love. And I do my own practice of meditation and journaling, not as often as I think I should, but I try to give myself a lot of empathy with that, with having young kids and stuff like that.
That's a practice too.
Giving oneself empathy is
Huge.
a very important practice. Thank you for saying that.
Yeah, people can miss that and even be hard on themselves for not doing self-care, which doesn't make a whole lot of sense, but it happens.
That's right.
And so I'm curious, how do your parents feel about your career now that it's full-fledged?
I think they know that it's alive in me. I think there are times when they probably wonder, what if he had done something more different than what we did? What if he had been a surgeon, or what if he had been an engineer? Would that be interesting? But I think that they see me, they know that this is something that I love, and I think that they appreciate that.
That's awesome.
Yeah.
Is there any final thoughts you'd like to share?
No, good conversation.
Yeah,
I appreciate the opportunity.
Yeah, we covered a lot of ground.
We did, didn't we?
If viewers want to get in contact with you or an organization that you're working with, how could they learn more?
Well, if they're viewing from Tennessee and they need addiction treatment, there's actually a red line for that you can Google, the Tennessee Red Line. For the national audience, I would say please get in touch with the TNT program leadership, and they can pass the message on to me.
Wonderful. Appreciate you coming and sharing your insights with us.
My pleasure.